Welcome. In this video, I'm going to discuss how I look at an ECG in the ED and what I'm looking for. At the end, I'll discuss how we'll apply a basic approach to interpreting ECGs over the course of the year. I remember being mystified as a sub-I watching attendings sign ECGs within a few seconds. I soon figured out that they were just looking for STEMI criteria meeting ECGs, which partially explained the speed. We're going to talk about how to be efficient from the beginning. However, I think we need to reframe the question too. I think the better question to ask rather than is it a STEMI is, do I need to do something right now? I answer this question by answering three more. Is there an ischemic problem? Is there a conduction problem? Is there an electrolyte or toxicologic problem? Some emergent ECGs don't fall into these categories, but they are the exception. Since I said I'll do something, I'll go ahead and clutter up the slide with what we might have to do next in these situations. Beyond the large category of normalish ECGs that we encounter, I think that we can categorize most abnormal ECGs into three broad categories. The do something now category, discussed, comprising ischemia, conduction, and electrolytes tox. The do something category, comprising strain in structure, risk of sudden cardiac death, and other acute illness. And the get fooled category, comprising lead placement problem, artifact, and mimics. If you can reasonably rule in or out the above, you have most likely done your duty as an ED ECG interpreter. For now, though, let's focus on the do something now category and go over an approach to efficient ECG interpretation in a busy clinical setting. So a technician hands me an ECG. Here's how I look at it in 5 seconds. First, clinical context gives me a sense of what to look for. Then I look at the rhythm strip to establish an AV relationship. Then I look at the leads. When I look at the rhythm strip, I look for the three R's: rate, regularity, and most important, related P's. I also look for the QT interval here. If I have multiple rhythm strip options, I'll look at lead 2, the best place to see P waves. Related P waves is essentially AV relationship. Then I look at the leads to look for QRS characteristics, axis, repolarization abnormality, and extras. I look for all these things at the same time. Polarization is the essential question here. This covers ST elevation and ST depression. As far as I'm concerned, the only rule to reading ECGs is to look at the whole thing, every wave. Here's an animation showing how I try to do that. Half a second to see the whole thing without focusing, 1.5 seconds to scan the rhythm strips, 1.5 seconds to look at the limb leads, 1.5 seconds to look at the precordial leads. If it's clearly a sinus ECG, this really probably does take 5 seconds. If there are some features that trigger my curiosity, I might take another 5 seconds. Of course, beginners will take longer, but I think this is achievable for you by the end of residency. Let's apply this by taking a look at this ECG. You don't need to be particularly systematic to notice a problem here. Start with the rhythm strip, first taking note of whether it's fast or slow. You can ballpark a speed by looking at the first 2.5 seconds. I can tell that it's somewhere between 24 and 48 because there are only 2 beats right there. Let's not get bogged down in explaining this right now. Since this is slow, you could also count QRSs, which gives me 36, 6 complexes times a 10-second rhythm strip. But let's be clear here. I'm not trying to get an exact number. I just want a sense of, is this fast? Is this slow? Is this about normal? Regarding regularity, the QRSs look grossly regular. Now to the AV relationship. Is there a P wave before every QRS? Scanning along, I see there's not one before every QRS at a fixed interval, therefore not sinus. Then I see we've got consecutive P waves. We've thus identified at least a second-degree heart block. Now we ask whether the ventricles and the atria are communicating by seeing if the P's are regular. Start with the consecutive P's. The P's are regular here, which is concerning for a high-grade heart block. Of note, it takes some practice to see P waves buried in other parts of the waveform. When we see that the R waves are also regular, it pretty much confirms complete heart block. The P's and R's are regular and unrelated. Now, let's move on to intervals. The QT looks like less than half the RR interval, which gives us a sense that it's normal, and the QRS looks narrow, less than 3 small boxes. After addressing whether the rhythm is sinus, we then address the ischemia question. I start with V1 and AVR first, the right-sided leads, then go left to right in distributions. 1 in AVL for high lateral, 2, 3 in AVF for inferior, and I look at the precordial leads in order. As I look at these leads, I answer the question of whether I'm seeing elevations or repolarization abnormalities that could represent reciprocals or otherwise indicate active occlusion. Start with the right-sided leads because there's a lot you can notice off the bat by looking at the right-sided leads first. Left bundle branch block, right bundle branch block, VTAC, and arm lead reversal are good examples. Back to our ECG. At this point, I've noticed the following thing. There's elevation in the inferior leads, and there's widespread repolarization abnormality that represents high lateral reciprocals, lateral precordial reciprocals, and perhaps posterior extension of infarct given the depressions in V1 through V4. This is a case of acute right coronary artery occlusive MI. You can see here how that would cause complete heart block. The His bundle is the conducting bridge between the nodes and the ventricles, and it's mainly RCA supplied. So it wasn't hard to recognize a STEMI in this patient. But that also might have made it easier to miss the complete heart block. This patient needs to go to the cath lab, but we also need to be ready to pace the patient, use vasopressors, or all of the above. This is why it helps to be systematic, to not get distracted by one feature before looking at the others. At a minimum, I think that your system should involve you confirming related P's first before looking for other stuff. Then get in the habit of looking at ECGs in a way that ensures that you look at all the leads. Now that we've discussed a way to look at ECGs, here's the information that you'll need to interpret them correctly to answer whether you need to do something right now. I have crammed it onto a 2-sided sheet of paper, and this is the top half of the first page. It contains nearly all the information you need to recognize ischemic, conduction, and electrolyte/toxicologic emergencies, and is organized as above. Based on past feedback requesting summary material, I have attempted to make the ultimate summary. The idea is less that you memorize the sheet and more that you internalize it by applying its contents to the task of interpreting and acting upon the ECGs we encounter in my lectures, if you're working on shift with me, or if you take the initiative to apply some of what I've discussed in this video to your own ECG interpreting life, wherever you may be. Thanks for your attention, and may your confidence grow in using this ultimate rapid and actionable diagnostic test to figure out which patients need something done now.